Well, there are some very new things to say since last year, actually, since June. Do you want to take that, Angie?
I can start it and we can all pass around. So I think in the past in this forum, we have talked about drugs that have been used, that have been tested to see if we can reduce the risk of breast cancer. And those have been tested in women that are at high risk for getting breast cancer. So a drug called tamoxifen that we use for breast cancer treatment can also reduce the risk. And a drug called raloxifene has also been tested and can reduce the risk of breast cancer. That's a drug that's commonly also used to preserve bone. And so these are both drugs that have been tested that do show a benefit. And now we have some additional data that the newer group of drugs, the aromatase inhibitors, also can reduce the risk of breast cancer. Unfortunately, these drugs do have side effects, and it can be a very hard decision for women to take these drugs, even if they know that they are at risk, either through their family history or because they have been found to have a mutation in one of the genes like BRCA1 or BRCA2. Even though the reduction in risk is really significant, the side effects often can scare people away from taking the drugs. And so it's a long discussion that we have. And it's important to get a really accurate sense of what your risk is. And you can do that through your primary care doctor, or you can go to one of the risk clinics that most major cancer centers have, really designed to sit down and say, let's look at the models that we have. What are your risk factors and what is the likelihood that you'll get breast cancer? And then you can weigh that risk against the side effects of these medications. But there are also things you can do that are not medical to prevent breast cancer. And so I think what we're learning is that there are specific lifestyle things that women can do that do reduce their risk of breast cancer. Certainly there is a link to alcohol consumption. And although it has never been completely clear how much alcohol is okay, and we are learning that, over a certain threshold, and that might be something like 4 to 5 drinks a week, the risk of breast cancer does go up. So there is a link there. Obesity is another thing that increases the risk of breast cancer, and some of my colleagues can talk more about some of the mechanisms underlying that. There's been some controversial data about whether vitamin D deficiency is linked to breast cancer, data on both sides of that issue. Vitamin D deficiency, it turns out, is almost epidemic in this country and among women, particularly women of menopausal age. But the degree to which vitamin D deficiency contributes to the risk of breast cancer is not completely sorted out. A lot of people are working on that. So these are things that you can do rather than taking a pill if that is not appealing to you. So we're learning more and more about exercise, physical activity, and other things really that can reduce the risk.
I'm going to try to stir the pot up here a little tiny bit. I have a slightly differing view from my colleague about this. There's no point in research if you don't take advantage of it. And the data are set in stone that 5 years of tamoxifen or raloxifene will reduce breast cancer risk at least 50%, 50. And maybe for the aromatase inhibitors more. There isn't, I suspect for the people in this room who are over 50, I'm not asking for a show of hands, I suspect I won't find a single one who isn't on a statin. And statins are given out like they are candy. Everybody's on them. And believe me, they kill occasional people. They have side effects, and some people can't tolerate them. And I'm not personally happy with the argument. I know you'll get upset with me. I'm not happy with the argument that tamoxifen is going to be so devastating in terms of side effects. The fact is that in randomized studies, when it was done against placebo, the majority of women could not correctly identify whether they were on the drug or the placebo. So since you can stop the drug if you don't like it, it's not making you feel well, why wouldn't you give it a shot? And I feel that there's a gigantic defect in primary care general physicians in that they don't do it. The drug reps don't flog them to do it because these drugs are all generic now and they're cheap. And I think that a tremendous number of breast cancers that ought to be prevented in this country aren't. That's my view.
So go ahead and clap for Mark, but I'd like to make a counterpoint to that.
I told you I was stirring the pot. Somebody's got to do it.
No randomized clinical trial in the prevention setting of tamoxifen versus placebo has saved a single life due to breast cancer. We've reduced incidence. We don't save lives. And
We don't know if we save lives.
well, it wasn't powered.
Right.
It wasn't powered for that endpoint. However, we haven't shown that we save lives. And I agree with Mark that in younger women with very high breast cancer risk, the serious side effects are low, but they go up by age. And a stroke, blood clots, even cataracts are increased. There are a lot of other side effects. So it shouldn't be put in the drinking water, is what I'm trying to say here. It's not for everybody. I do agree that we probably out in the primary care community don't talk with women who are at high risk and might benefit, but I also worry about saying we should be giving it to 70-year-olds routinely for prevention of breast cancer who have much greater health risks. So I think there's, it's got to be balanced.
Go ahead, you have a
And
report.
I think that we can all agree, actually, that there is a subgroup of women who really do stand to benefit from prevention strategies. And those are women who are carriers of the mutations in BRCA1 or 2. And risk factors for being a mutation carrier are having a lot of breast cancers or ovarian cancers in your family, multiple people who have breast cancer under the age of 50, or people who have bilateral breast cancer. And so there is a test, it's a simple blood test to be able to find out if you have one of these mutations. It's always best to do it in the setting where you can also have genetic counseling so you can really understand whether or not it's a test you want to have and what the implications of the answer are. But if you find out that you do have one of these mutations, it means that you have a very, very high risk of getting breast or ovarian cancer in your lifetime. And prevention strategies clearly work here, and they can range from having more frequent screenings with MRIs in addition to mammograms, to the more drastic approach of having prophylactic surgery and having the breasts or ovaries removed, or in addition, taking one of these drugs. I think we can all agree that in those very high-risk women, prevention strategies, including the use of these medications, is very important.
Mark?
Over this way.
I just have one.
I'm sorry,
a few-
both, go ahead.
You first.
Me first? Okay.
I'm in charge, you're first.
As you see, the controversies on this are not settled, and we do have some trials here within the community that you could participate in. The big question right now is, what should we be doing with vitamin D? We have one trial open right now. We've been looking at this, trying to put patients on, and we realize we need another trial because we need to look at a larger spectrum of patients to answer the question, what should we be doing with vitamin D in patients who are high risk? So that's one thing that we're looking at. You can ask your physicians, they can call us, we can screen anyone who wants to be on those trials, and actually it would help me get the other one open if you actually asked about them. Thanks.
All right. I know you have a follow-up, but I promise we're coming to you.
So this is a research opportunity and a challenge to us in the field. If we could tease apart the beneficial effects of these prevention drugs from their side effects, such as blood clots or endometrial cancer, if we could separate those, then we might be able to develop a new class of chemopreventative agents. And that's exactly what collaborators of ours at SRI, Stanford Research Institute, are doing. They have a couple of lead molecules that are cousins of tamoxifen and raloxifene, but they think, at least in preclinical models, don't have some of the major toxicities of those agents. So that's a research opportunity.